Assalamu alaikum جميعا. We are waiting just for Dr. Said to join and we will start inshallah. Assalamu alaikum wa rahmatullah. I would like to welcome Dr. Said, Dr. Said Salim, pediatric cardiac surgeon from Saud Al Babtain Cardiac Center. He is joining us. Welcome, Dr. Said.
Thank you, Dr. Musallam. I'm happy to be with you in this lecture today.
Inshallah, today we will have two presentations or two lectures. One conducted by me about the bypass, and the second one conducted by my colleague, Dr. Sultan Askar, inshallah, about tetralogy of Fadl. Bismillah ar-Rahman ar-Rahim. I'm Dr. Muslim. Inshallah, اليوم I will talk about the cardiopulmonary bypass. The cardiopulmonary bypass in pediatrics. So, as an introduction, cardiopulmonary bypass allowing to operate the cardiopulmonary system to facilitate surgical repair, oxygenation of blood, and removing carbon dioxide, removing any permanent damage to blood or end organ. For pediatric perfusion, there should be a planning before the surgery because the equipment has to match the size of the patient, expected pump flow rates, the diagnosis factors depends on the type of surgery and the lesions that are with the patient. So here is a comparison between the infants versus adults. We have the immature organ systems, smaller circulation of blood volume, higher oxygen consumption rate in pediatrics, reactive pulmonary vascular bed, and presence of intracardiac plus extracardiac shunting, impaired temperature control, or tolerance of microemboli in the smaller or in the infants, Now here is the difference between adults and adults. As you can see, the estimated blood volume in adults, male 70, while the female is 60. While in pediatrics, it depends mainly on the weight of the patient. Dilution effects on blood volume, 25 to 33% of blood volume, while in pediatric patients at 50 even to 200 up to 200% oxygen consumption. Pediatrics higher, 6 to 8 milli per kg per minute, and also full cardiopulmonary flow at the the 37 Celsius degree will be 50 to 75 in male, while in the adult patients, while in pediatric patients depend on age. The lower the depends on the weight. The lower the weight, the higher the flow. As you can see, the minimum temperature differs. Pediatrics tolerate commonly less temperatures, surgery conducted at lower temperature. The temperature gradient 10 to 12 between the blood and the water, while it's about 8 in pediatric patients. Perfusion pressure differs also. Acid base, the alpha state in adults, while in pediatrics you can use alpha or the pH state of blood gases. Also, the tolerance of the partial pressure of carbon dioxide. Pediatrics tolerate even 60. Physiological differences between the immature and the mature myocardium. The energy substrate, adult myocardium, undergo aerobic condition, derives 95% of ATP from oxidation of long chain fatty acids. So they are dependent on long chain fatty acids, while neonatal heart derives the ATP from oxidation of glucose in aerobic as well as anaerobic conditions. That's why the neonate heart or immature heart tolerate ischemia, has a greater tolerance to ischemia than the adult one. The substrate change from glucose to free acids is due to an 5' adenosine monophosphate activated protein kinase, and this period uptake of glucose reduces the leading leading to increase in insulin and more glycogen storage, subsequently less ischemia tolerance in case of fatty acids adults. The calcium metabolism is very important. It's more sensitive and dependent on extracellular calcium. Less developed sarcoplasmic reticulum, and this allows for reduced the calcium ATPase activity, that active transport of calcium in the luminal side of the sarcoplasmic reticulum, and decreases calcium storage. This lead to let's say desensitization and reduce the renal receptor activation. So what is the factors that lead to the ischemia tolerance of the immature heart? So this immature heart has a greater tolerance to hypoxia and also greater glycogen stores, improved anaerobic metabolism, and better maintenance of ischemic calcium exchange, higher levels of adenosine triphosphates for energy, and increased amino acids substrate utilization. Those are parameters that make the neonate heart more tolerant to ischemia. So for protection of the myocardium, generally for adult or pediatrics, with a difference of detailed difference, let's say, where the hypothermia is one of the methods, and hypothermia reduces the myocardium oxygen consumption through the metabolism. The higher the temperature in the body, the more oxygen needed to conduct the full metabolism, metabolic cycle. The cardioplegia arrest is very important, especially when dealing with the myocardium. Smaller circulatory blood volume. So the circuit capacity cannot be reduced proportionate to the patient size. So significant hemodilution is needed what may happen? Decrease in clotting factors and plasma proteins leading to the dilutional coagulopathy. Colloid osmotic pressure decrease leading to interstitial edema, electrolytes imbalance, and increase the release of stress hormones and activation of complement white blood cells and platelets. And you need as much as 200 to 300% of patients' blood volume. And in adults, as I said in the beginning, we need only 25 to 33 of patients' blood volume to be diluted. Now, speaking about the priming solutions and hemodilution, common prime constitutes plasma, and there are several types of plasma, as you can see in the table above, like types of plasma comparing with the Ringer lactates and Hartmann solution. Also, we may add heparin, calcium chloride, sodium bicarbonate, even antibiotic can be added, albumin, and whole blood. In fact, in pediatric surgery, we need to maintain the hematocrit in a specific window. So for this, we need to anticipate the starting of the bypass after priming. We should start with the specific with the initial, let's say, initial value of hematocrit, and not to have the blood, let's say, too much diluted or concentrated, more concentrated. And also this may depend on the lesions that the patient have at the time of the procedure conducted. Comparing priming solutions and literatures found that the albumin and versus crystalloid albumin prime significantly reduces the on bypass drop in platelet count. Fresh frozen plasma versus the crystalloid, there was no difference in risk of postoperative bleeding and need of transfusion of allogenic blood products. Reconstituted fresh whole blood versus standard blood component therapy. There was a study on this. They found that this just tube drain and shorter length of mechanical ventilation and intensive care units stay when using the reconstituted. Now, as initially I stated that the higher the temperature of the patients, we need to have higher flow rate, and to let's say monitor this flow rate. We need to take a look at the serum lactate. Serum lactate is one of the important parameters to see the perfusion state of organ and the conversion from the aerobic to anaerobic respiration or oxygenation or production of ATP, in another word. Determinants influencing the blood flow. So pediatrics with congenital heart disease, what may determine the blood flow? When you have the anatomic heterogeneity of patients, difference in age-based and weight-based flow of blood. The mixed venous oxygen saturation is an indicator of adequate systemic blood flow, but it does not directly measure the adequacy of cellular oxygenation and the oxygen consumption of the tissue. Serum lactate indicate the presence of anaerobic metabolism and also better reflect the adequacy of cellular oxygenation. Should routinely be measured 10 minutes after the initiation of bypass, plus every 30 minutes consequently. Now, how we assess the urine function by urine outputs on the bypass will be assessed. And so this is an end organ that we need to plus the oximetry for brain oximetry, also for brain as an end organ. So how to minimize the need for transfusion in pediatric congenital heart surgery? We need to minimize the that need of transfusion and bringing more substance to the patients. So tolerating low hematocrits, this is one of the methods. A second method is tolerating very low priming volume, and also modification of priming solutions. As I stated previously in one of the slides about the priming solutions, there are many priming solutions that you can use, and some of them has upper hands than the other. Putting the proper, or let's say the most accurate, depending on the outcome that we need to find in the patients, we can adjust and modify the priming solution. So one of the hands that they use of retrograde autologous priming in pediatrics, particularly neonates and infants, so smaller patients or younger patients, appears to have limited practical use, and this technique is not yet adopted. So how to monitor the blood need of blood transfusion? There is a technology called the near-infrared spectroscopy, which scans the blood components and allow the clinicians to tailor, the surgeons or perfusions to tailor blood, or anesthetists to tailor blood transfusion intraoperatively based on real-time data during the various stages of operation. Now, what about ultrafiltration? Ultrafiltration is the excess volume of the capillary venous reservoir. So we have examples of this excessive volume: crystalloid component of cardioplasia, given crystalloid valve testing solutions, for example. And there are two methods of ultrafiltration. One is called conventional, and the second one is the modified ultrafiltration, conventional ultrafiltration. The conventional one is utilized in nearly all pediatric bypass cases, while the modified allows the ultrafiltration of the circuit's volume as well as the patient blood after weaning from bypass. So the conventional during bypass, modified after weaning from bypass. And how does this give any benefit to the patients? Now we turn to the advantage of the modified. Modified appears to have higher post-bypass hematocrit, so we keep higher hematocrit, higher concentration, good oxygenation, and also higher mean arterial pressure, and minimize inflammatory cytokines reactions post-bypass. Here is the alpha state versus the pH state of the blood gases. As you know, the alpha state and pH state is corrected due to the alkalosis happens. We correct the blood gases by adding CO2, while in alpha state is the same reading at the same temperature of the blood of the patients. So in pediatrics, I stated previously in the comparison table between the adults and pediatrics that in adults we use the alpha state, while in pediatrics we use the alpha and pH state of the patients. Now is the second part of the presentation, which I will speak about, inshallah, the lesions, some lesions, selected lesions, and how the bypass will be conducted in each lesion, inshallah. First one will be the aortopulmonary collaterals, major aortopulmonary collaterals ligation before CPP, before the cardiopulmonary, should be tried, otherwise systemic flow compromised, because there is a connection between the systemic circulation and the pulmonary circulation. Flow increased 23.5 to 5 liter. Anticipated oxygenator cannula flow will be increased first to increase the blood pressure, sure, and using the near infrared spectroscopy, the technology I stated before. Ventricular distension, for ventricular distension, we need to put LV vents. Temperature decrease, compromise systemic and cerebral circulation. Hematocrit of 30 to 35 during bypass compromised the cerebral blood flow, and pH state increasing the CO2, as it is the blood gas is corrected by CO2. This will lead to the cerebral vasodilation plus the pulmonary vasoconstriction. Also, blood products in this type of surgery, aortopulmonary collaterals, need to be kept in hand due to the increase in blood flow, as we said previously, and the reservoir it can become empty, so we need to keep the blood products just in hand. Alpha agonist, the use of alpha agonist, this is debatable. They increase blood pressure and causing systemic vasoconstriction, leading to a decrease of circulation, increase also the pulmonary circulation. Bidirectional Glenn shunt, the superior vena cava cannula will be placed in the innominate vein or higher in the Sabinus vein, in the superior vena cava. Lower cannula may be placed in the atrium instead of the inferior vena cava if no additional intra cardiac work is needed. So for extracardiac lesions, we may put the cannula in the atrium, venous cannula, for the intracardiac bicaval cannulation, or innominate and the inferior vena cava cannula. This is a general. So cardioplegia is not normally required in such a procedure. LV vent normally is not needed because there is no distension. We do not anticipate the distension of the LV. Be aware of the status of the BTS shunt and the Sano shunt also. So control immediately on bypass, if not increased pump flows to compensate of the pulmonary runoff. The CVB displayed will be useless, I think, if the severe vena cava clamp includes the catheter. So there is no proper measurement of the CVB. In Fontan procedure, high hematocrits may not need blood in the prime. We spoke previously that how to minimize the blood need. So it depends on the procedure. If we have a high hematocrit, so we don't need to add blood in the prime, and also may receive FFP to correct the factor deficiencies. Cardioplegia required for the lateral tunnel technique, which is creation of a tunnel using the pericardium and the external surface of the right atrium to connect the inferior vena cava to the pulmonary circulation, pulmonary artery. Bicaval cannulation, as I stated previously, is superior vena cava cannula higher than normal or in the innominate vein, and the inferior vena cava cannulation lower than normal to facilitate creation of intra-atrial baffle or extracardiac conduit as in the lateral technique. Again, the same with Glenn and Fontan. The CVB may not be accurate. BDA lesions, BDA lesions, petenclitic sartoriosis with the outer cardiac lesion, normally closed without bypass, this type of surgery. If bypass needed, so flow increased 3.5 to 5, flow to be increased first to increase blood pressure, use the nurse. Ventricular distension and BDA may occur, so LV vent is needed. For rectal temperature is not recommended, and also here the alpha agonist is better to avoid because after ligation of the ducts, the blood pressure will be really high. Coarctation of aorta, left heart bypass, left atrium to the descending aorta, femoral artery for isolated coarctation, repair, flow to the descending thoracic aorta to be titrated depending upon upper body circulation. If complete bypass, flow to be decreased when the descending is clamped to avoid overflow to the cerebral circulation. We have the interrupted aortic arch, two arterial cannula, ascending aorta, and PTA are needed for true interrupted arch. Cardioplegia required, circulatory arrest for correction, of course. This is an aortic surgery. Regional perfusion techniques, the pump flow of 20 to 60 cc per kg per minute through the arterial cannula with flow directed to the cerebral and somatic nerves. Monitoring is commonly used in this. So we have two types of monitoring at this interrupted aortic arch procedure. Left superior vena cava, left superior vena cava. If we have a lesion like right and left superior vena cava, if bridging vein is present, or if the left superior vena cava flow is minimal, it's not really high, pump sucker in the right ventricle, this is a solution. Low flow sucker can be placed in the directly in the superior vena cava left, and it may be ligated below the bridging vein. If bridging vein is absent, third cannula, venous cannula may be used. So the first one will be in the right superior vena cava. Second one will be in the left superior vena cava, and the third one will be in the inferior. I think this is the last lesion, and almost left coronary artery from the pulmonary artery. In this particular lesion, we just need to remember that there's the left coronary artery arises from the pulmonary artery. So in cardioplegia, we need to place the cardioplegia in the roots, pulmonary roots, and also the aortic roots to allow adequate cardioplegia to the coronary in the coronaries, and also left and right pulmonary arteries should be controlled before cross clamp to ensure that the cardioplegia delivered to the anomalous coronary artery. Thank you very much. This is my reference, and thank you for listening. I will allow the time for any discussion, any point Dr. Saeed would like to raise or to comment on anything, please. You can.
Yeah. Thank you, Dr. Muslim. Thank you for having me today, and you did it very well. The presentation is excellent, involving two parts. The first part discussing the physiology of cardiopulmonary bypass in pediatric, especially versus adult, and the second part emphasizing some anatomical substrates which are different from adult, especially regarding the site of cannulation and anatomic variations. My advice is, I think there are a lot of debate and a lot of knowledge detail regarding the pediatric perfusion, and I recommend that every one of you should study it and to be aware about the physiology of pediatric perfusion. And the most important message that I want to deliver today is that I noticed that some of you, or mostly all of you, did not put an eye regarding the perfusion, even in adults. To be a good surgeon, I think you should know about the perfusion. You should study, and you should discuss with your. Every case should be discussed with your perfusionist. You should have that there are some difficulties during the pediatric perfusion and some deviation from normal. As you stated now, sometimes like if you have a patient who's interrupted aortic arch, you have to put two cannula, two arterial cannula, not one. The SVC, left SVC is present in 2% of patients. So it will be encountered a lot if you don't have experience how to deal with. So if also regarding the hemodilution, what to do when the patient's hemodiluted or you have like some collaterals. So a lot of issues you have to know, and the pediatric, the perfusion in general is very important. Like you help the other surgeons, and you are not carry the responsibility because he's dealing with the difficulties. But when you are just the main surgeon, you have to solve the problem. If the perfusionist have a problem, you have to cooperate with him. You have to solve the problem, like venous drainage issue or distension, or if you have PTA or collaterals. A lot of issues should be in your mind. So when it happens, you have the strategy to deal with. So please don't ignore perfusion issues. You should know, and this is my advice today. Thank you for your presentation, and I'm happy for any discussion or question for me or for Dr. Muslim.
Thank you very much, Dr.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Can I ask two questions, if you don't mind?
Yes, sure.
First, I would like to thank you on your great lecture. Really, I enjoyed it. I wish you added just like a section about common problems that are specific to pediatric perfusion issues, like and how to deal with them. My two questions. First, you mentioned in the myocardial protection two types of cardioplegia, blood cardioplegia and Delnado. Can you please elaborate more? What are the differences between blood and Delnado cardioplegia? That's the first question. The second question, I have a concern regarding the best perfusion strategy for patients with persistent PDA. Like if I cannulate a patient with a persistent PDA the regular way, is there a risk that I will drown or shower the lung with too much volume and the patient will suffer from pulmonary edema post-op or not? Thank you.
Okay. So for the first question, yeah, of course, the way of myocardial protection in pediatric is different, and there are advantage and disadvantage for each of it. There is no much like meta-analysis comparing these methods. We have other methods also, like custodial cardioplegia, commonly used nowadays in pediatric, not only Delnado and blood cardioplegia. But for your question between blood cardioplegia and Delnado, yeah, Delnado is coming or frequently used nowadays. It is giving like 70 to 80 minutes per dose. So if you have like blood cardioplegia, you have to give the next dose every 3 minutes. Sorry, every 30 minutes. So it give Delnado cardioplegia give you more time in frequent doses. So mostly for even complicated cases, you give also in the first and second dose. For blood, you have to give repeated doses also to give the myocardial protection. Regarding the cellular or microcellular differences, some papers document that Delnado cardioplegia is better for some lesions, but blood cardioplegia also is in another papers or studies giving good results and no difference between them. So it's I think it's commonly now there is no evidence that there is no one higher than the other. It's mainly a surgeon preference. For me, I prefer when I do like simple short procedure, I give just blood cardioplegia. and if prolonged, like 90 or 80 minutes, we give the needle. Sometimes for prolonged and the complicated procedure, like 180 or 150 minutes, we give custodial because it give you just to give single dose and go ahead doing complicated repair without interruption and without changing the field. For the second question, I think you ask, yeah, for the BDA. Yeah, of course, you have a risk if you are cannulating a patient requiring open heart surgery and cardiopulmonary bypass, like, for example, subaortic membrane or VSD, and you have additional persistent ductus arteriosus. Yeah, you have a risk because the compensatory mechanisms when the heart is beating is different when you are going on bypass. On pump, you have relaxed vascular tissue and the continuous flow coming from the aortic cannula. So when you go on pump, the BDA should be controlled either before you go on pump, just when before cannulation, or after cannulation before go on pump, okay, or shortly after going on pump. Because when you go on pump, the blood is sucked out from the vena cava to the oxygenator, coming back from the pump to the aortic cannula with continuous flow. So if the BDA is not controlled, so the blood will pass from the aorta to the pulmonary circulation. It will be flooded, sometimes leading to pulmonary edema and venous return to the left side, leading to ventricular distension, which is, if it is prolonged, uncontrolled, it will be very harmful. So if you have good experience, you can control even before cannulation. If you don't have experience, cannulate first, then go control the BDA before going on pump. So if any accident like rupture of the BDA or bleeding, so you can go on pump and control. Okay, or either you just go on pump, but keep the heart filled and ejecting, okay, with increased flow, and just to be ready to control it. With experience, it will be very easy. It will be controlled within 30 seconds or 1 minute after going on pump. Am I asked, is it okay, or any residual question?
Thank you, Dr. Salim, for the answers. I just need, regarding the Delnido and the blood cardioplegia, what are the differences in the component and how they are prepared? Are they the same, or
No,
there are differences?
Yeah, good question. No, it's blood cardioplegia is blood. Just it's a blood from the oxygenator taken into a side way, given to in the aortic root before the cross-column, the aortic. So it is a blood component. The proponent of this cardioplegia saying that the blood is a natural solution that go to the coronary, so containing the hematocrit and all blood constituents that is normal for the heart. So it is a better cardioplegic solution if we added something which lead to stopping of the heart. So it is mainly blood from the oxygenator plus potassium that is calculated according to the body weight and given in through this blood to the heart. But Delnido cardioplegia is a solution which is prepared. Sometimes some people have it's a ready-made solution like a vial containing the constituent, as Dr. Muslim explained in his presentation, like sodium and potassium, magnesium, lidocaine, a lot of components, which is sometimes come ready-made, or some perfusionists can made it, take this the constituents and made it hand-made inside the OR and inject. So it is certain constituents of blood based mainly on the natural constituents of the blood, beside, of course, potassium, just to get the depolarizing cardiac arrest. Okay.
Clear, doctor. But so the Delnido is a crystalloid, not a colloid solution, right? It does not have blood.
Does not have blood, but there is a colloid because it is the main solution for it is plasmalyte. And it's plasmalyte. So a colloid solution, but not blood.
So it's not like a custodial, the custodial, which is a crystalloid.
Yeah, custodial is crystalloid based, but the constituents is different because they bring high potassium, low potassium and high sodium. So it is the cellular mechanism of custodial is different, but it is crystalloid based.
Okay. Thank you very much, Doctor. Thank you.
Thank you. You're welcome. Any other question, Dr. Muslim, or from the attendees?
Any questions? I think maybe there is no question. Thank you very much, Dr. Sayed. Again, we may start the second lecture in 10-minute time, 13:55. With Dr. Sultan. Dr. Sultan will continue the second lecture in 10 minutes about the tetralogy of Fallot. Thank you very much.
It's colloid. It's colloid based. Yeah, it's plasma line. This solution.
Assalamu alaikum. May I start my presentation?
Your voice is clear, your presentation is clear.
Okay, may I start? Okay, Assalamu alaikum. Good afternoon, everyone. My name is Sultan Askar, cardiac surgery resident at Prince Sultan Cardiac Center Al Hassa, and today, inshallah, I'm going to be presenting about tetralogy of Fallot. So the objectives of my presentation, we're going to talk briefly about the embryology, the anatomy, the pathology, the presentation, and the management. So tetralogy of Fallot is the most common form of cyanotic heart disease. It occurs in approximately in 3 to 4 in every 10,000 births. It accounts for about 3.5% of congenital heart disease. It was first described by Dr. Fallot in 1888. As the name implies, there are 4 lesions or 4 malformations involved in tetralogy of Fallot. They are a ventricular septal defect, a right ventricular outflow tract obstruction, which can include the valvular pulmonary stenosis, subvalvular pulmonary stenosis, or supravalvular pulmonary stenosis, an overriding aorta, and a right ventricular hypertrophy. This image summarizes the findings. As you can see, there is pulmonary stenosis, there is a right ventricular hypertrophy, an overriding aorta that actually straddles the VSD. So, and the aorta is more rightward, and due to the shunting, is actually more dilated. So the risk factors for developing tetralogy of Fallot are mostly genetic. However, in some cases, there are some maternal risk factors that, and if mothers are exposed to these factors, they can run the risk of giving birth to babies with tetralogy of Fallot. They include uncontrolled diabetes mellitus, uncontrolled phenylketonuria, retinoic acid exposure, and trimethadione exposure, which is an anti-epileptic. Genetic factors are, however, the most common ones, and usually people with tetralogy of Fallot have DiGeorge syndrome or velocardiofacial syndrome, which come from the 22q11 deletion. Trisomy 21 is also a common cause of tetralogy of Fallot. Some rare causes of tetralogy of Fallot are Cat-Eye syndrome, Kabuki syndrome, or Alagille syndrome, but these are rare. The most common ones are DiGeorge and trisomy 21. These are the most common causes of tetralogy of Fallot. So this picture shows the normal anatomy of the heart. As you can see, this is where the conal septum is and where it should be in normal heart. The septal band, as you can see, has 2 limbs, a superior and an inferior limb, and in between these 2 limbs is the conal septum. This is the area where the VSD is usually located in patients with tetralogy of Fallot. The VSD is usually anterior and superior. There is anterior and superior dislocation, if you will, into the pulmonary trunk, which causes the VSD and the crowding of the pulmonary valve, leading to RVOT obstruction. The embryology of tetralogy of Fallot, at around 28 days of fetal life, the heart tube loops around itself to reveal the morphology of the left and right ventricles. The conotruncal cushions usually develops after this, and from the conotruncal cushions develop the right and left, the pulmonary and aortic artery, and they sort of develop in a helixical way, in a helix, to construct the conotruncal septum. Any error in development in this step usually leads to the development of tetralogy of Fallot, leads to the formation of the VSD. There are 2 theories as to why tetralogy of Fallot happens. There is the Van Praagh theory and Robert Anderson's theory. Van Praagh says that underdevelopment of the subpulmonary conus during cardiac morphogenesis is the single event that leads to the development of tetralogy of Fallot. The result of RVOT obstruction leads to underdevelopment of the pulmonary valve, pulmonary arteries, and that in turn will cause right ventricular hypertrophy. The shortened coronal septum usually fails to fuse with the ventricular septum, resulting in a malalignment, VSD, and the aortic override, according to Van Praag, is existing in normal hearts. However, it is more exaggerated in the tetralogy of Fallot. And there is usually aortic dilatation secondary to increase right to left shunt in utero. Anderson's theory is that tetralogy of Fallot originates from the anterocephalous deviation of the coronal septum. The anterior and left superior deviation of the coronal septum, as we discussed earlier, is the cause of the RVOT result in, and that in turn results in pulmonary stenosis. So we'll discuss the lesions of tetralogy of Fallot separately. So the VSD usually is a malalignment type. It can be said to be perimembranous, and it is non-restricted. It allows blood to flow freely from the two chambers. As you can see here, this is the normal heart. This is a patient with tetralogy of Fallot, and you can see the coronal septum is there. It's not absent. However, it is displaced upwards and leftwards towards the pulmonary valve. It crowds the pulmonary valve, which will lead to pulmonary stenosis, RVOT obstruction, and so on. In right ventricular outflow tract obstruction can be found at multiple levels throughout the RVOT. Usually, the narrowest area is at the pulmonary valve, with a dysplastic and underdeveloped valve and annulus. The valve itself is usually bileaflet. The obstruction can occur within the main pulmonary artery, or it can extend into the branches of the pulmonary arteries. The degree of left to right shunt is determined by the degree of RVOT obstruction. The more there is, the more obstruction there is, the more shunt from the right to the left ventricle. In cases of long-standing infundibular narrowing, a fibrotic endocardial proliferation can contribute to the obstruction. So the RVH is usually secondary to outflow obstruction and systemic vascular resistance, because the RVH is having to work against a tight RVOT. It usually undergoes hypertrophy. Actually, investigation of the architecture of the right ventricle reveals that there is an additional circular muscle layer within the right ventricle, which is usually not seen in normal hearts. And further microscopic examination of the myocardium in patients with tetralogy of Fallot reveals that there is myocyte hypertrophy and myocardial fibrosis in both the right and left ventricle. And this may lead to development of arrhythmias and runs the risk of patients having suffering from sudden cardiac death. The aortic override, as we said, the aorta is displayed anteriorly of the right ventricle to varying degrees depending on the VSD. With the coronal septum displaced from its normal position, the aorta lies more anterior and rightward and straddles the ventricular septum. The right to left shunt leads to increased flow across the aortic valve, which in turn may be a contributor to dilation of the aortic annulus and ascending aorta. This is just the same picture. It shows you that how the aorta overrides the VSD and leading to the shunt and the dilation of the aorta as described. Other abnormalities that patients with tetralogy of Fallot can have, they can have a right aortic arch with mirror image branching in up to 25% of cases. In approximately 5% of cases, the anterior descending coronary artery will arise as a branch from the RCA and will cross the RVOT. And this is actually important to know so that when planning surgery for patients with TOF, you don't want to injure this artery inadvertently. So there is usually a fixed and a dynamic obstruction at the level of the infundibulum, where the obstruction to flow into the main pulmonary artery increases during progression through the systole. Those patients who are born with the severe fixed obstruction will present with cyanosis as soon as the ductus arteriosus closes. And in these cases, usually these patients need to be put on prostaglandins to keep their ductus open, because they rely on their patent ductus arteriosus for blood supply to the pulmonaries. The pathophysiology, as we said, the RVOT obstruction worsens over time. The subpulmonary region becomes more stenotic. The RVH will increase due to the fixed degree of obstruction and the afterload as a result of unrestricted VSD, because the VSD allows blood to flow freely from the right to the left ventricle. As the obstruction worsens, there will be less pulmonary blood flow and increased right to left shunting at the level of the VSD, leading to lower oxygen saturation, which is why patients with tetralogy of Fallot have low oxygen saturations and present with sometimes hypercyanotic spells. So the presentation, it varies according to it varies from patient to patient, and that is according to the degree of pulmonary stenosis or RVOT obstruction. So the more severe the RVOT obstruction, the earlier the presentation, the more severe the presentation. In patients with severe obstruction, critical cyanosis occurs as the ductus begins to close. And infants with mild to moderate obstruction will have usually saturations in the 80 to 90% range. Patients with mild VSDs or mild pulmonary stenosis, usually have a more indolent course. They will not show symptoms. They may present when they are a little bit older. They may come with dyspnea on exertion. They easy fatigability, because usually when earlier in life their pulmonary stenosis is mild. However, as they grow up, the pulmonary stenosis will worsen, and that will lead to symptoms to appear. Usually, patients present with blue lips and blue nail beds. The auscultation will reveal a systolic murmur heard at the left sternal border, and radiates to the back. The obstruction, as in tetralogy of Fallot, as the obstruction worsens, the murmur will decrease, because there will be more blood flowing through the VSD, which will lead to less audible murmur. Because the murmur is actually because of the pulmonary stenosis, but as less blood flows to the RVOT and flows more into the LV chamber, the murmur becomes less audible. Patients with tetralogy of Fallot usually squat, and what squatting does is it increases systemic vascular resistance, which leads to a decreased shunting and increased blood flow to the pulmonary circulation. That in turn will reduce hypoxemia and may offer some relief of symptoms. We'll talk now about tetralogy spells or hypercyanotic spells. These spells occur at times of stress or agitation and can follow feedings, cryings, or bowel motions. They are characterized by severe systemic desaturation and are usually accompanied with tachypnea and can lead to loss of consciousness. They can lead to prolonged hypoxia, seizures, syncope, cerebrovascular accidents, and can ultimately prove fatal. Some books say that you should take the patient to surgery after the first TET spell. And the presence of tetralogy spell should prompt the surgeon in some cases to take the patients to OR earlier than planned sometimes. The exact mechanism of tetralogy spells are still unknown. There are two theories. One theory is that there is a spasm of the infundibulum during the time of stress, which can be due to catecholamine surge, which also activate beta receptors in the peripheral vascular, causing vasodilation. An alternative theory is that the right to left shunting is increased as a result of decline in systemic vascular resistance, which may lead to hypercyanotic spell. This picture summarizes the hypercyanotic spell. As we said, these are the two theories. In case there is an infundibular muscle spasm, there will be increased right to left shunt, which will mean less blood flowing to the RVOT, which will lead to increased hypoxia, acidosis, and increased pulmonary vascular resistance. that will also will cause tachypnea and will increase systemic venous return. This is like a vicious cycle of the tetralogy spell. X-ray usually shows a classic sign of a boot-shaped heart. Echocardiography, as you can see here, this is the VSD, this is the aorta, this is the VSD, and the aorta straddles the VSD and is actually deviated a little bit to the right. This is another echo, Doppler wave echo. The Doppler wave shows continuous Doppler and what is known as a double envelope sign, characteristic of tetralogy of Fallot. Untreated patients will usually suffer consequences of cyanosis, which include hypercyanotic spells, as we discussed them, and long-standing polycythemia. Polycythemia can lead to cerebral abscess formation and cerebrovascular accidents. And approximately 50% of patients without treatment will be alive at 2 years, 20% will be alive at 10 years, and less than 10% survive to 20 years of age. That is, if they are not treated. Acute management of a hypercyanotic episode usually is aimed at reversing the shunt at the level of the VSD by increasing peripheral vascular resistance. And that can be done, that can be achieved by putting the knees to the chest, knees to chest position, by giving the patient phenylephrine, oxygen, or morphine. Sometimes even beta blockers which decrease the heart rate, that in turn will result in increased filling and stroke volume and increase the vascular systemic resistance, which will halt the tetralogy spell. These three people are credited with coming up with a technique for treating patient tetralogy of Fallot. This is Dr. Alfred Blalock, Vivian Thomas, a lab technician, and Dr. Helen Tossig, a pediatric cardiologist. These people came up with what is known as the classic Blalock-Tossing shunt, and where they anastomose the subclavian artery into the pulmonary artery, whether it's the left or the right, and that in turn will increase blood flow to the lung. Years later, they modified this classic Blalock-Tossig shunt because they found that in some cases patients have upper limb ischemia. So instead of anastomosing the subclavian artery into the pulmonary artery, they use a graft, anastomosed from the subclavian to the pulmonary artery. Other shunts came about, or Watterson shunt and a Potts shunt. The Watterson shunt, or usually anastomosing the pulmonary artery to the wall of the ascending aorta. The Potts shunt was using that technique, they would usually anastomose the descending aorta to the pulmonary artery. And however, it has to be noted that this technique is usually used for palliative treatment, not for complete repair of this of tetralogy of Fallot. However, when this technique came up, cardiopulmonary bypass was still not in use. So after the invention of cardiopulmonary bypass, surgeons were able to do complete repairs of tetralogy of Fallot. This is just another picture, shows the same thing. So when planning for surgery, usually two questions are asked. Are you going to give the patient a palliative or a complete repair, and if he or she is symptomatic? And the second question is when to repair in asymptomatic patients. I found this diagram used by the Texas Children's Hospital. In their practice, in patients with tetralogy of Fallot, if the patient is symptomatic and the patient is less than 1 month, they would put a shunt in the patient. If the patient is between 1 to 3 months and is symptomatic, and if he is less than 3 kilograms, weighs less than 3 kilograms with unfavorable anatomy, they will also place a shunt. If the patient is less than 3 kilograms, however, he has a favorable anatomy, they will do a complete repair. And if the patient is more than 3 kilograms, they will also do a complete repair. If the patient is asymptomatic, and they would usually wait until the patient is more than 3 months, and if he or she weighs more than 3 kilograms, they would go for a complete repair of the tetralogy of Fallot. So there are some advantages and disadvantages. Advantages of early repair. is avoidance of long periods of cyanosis, which may lead to some developmental problems in the child, decreasing the RVH, and fewer procedures. So you don't have to go in, put a shunt, and then wait for a while, and then come again and complete the repair. The cons of early repair is increased morbidity and mortality and higher rate of reintervention. Delayed repair, advantages of delayed repair is higher success rate, smaller ventriculostomy is usually needed, pulmonary valve usually can be preserved better if you delay the repair. However, the cons or the disadvantages of delayed repair is that you are subjecting the patient to possibly having cyanotic spells, and long periods of cyanosis can affect the brain development, as we said. So this right here is a transannular patch, or a mini transannular patch. We're now going to talk about the surgical techniques of repairing a tetralogy fellow. They incise from above the pulmonary valve into the conus, about 5 millimeters only into the conus. This is known as a mini transannular patch. This here is the classical transannular patch and versus the mini transannular patch. They found that in patients who underwent classical transannular patches, they had pulmonary regurg, arrhythmias, sometimes right heart dysfunction, and RVOT aneurysms, and sometimes even akinesis of the infundibulum. And some believe that the infundibulum plays a role in a vital role in right heart contractility and contributes to cardiac output. So they came up with this way of mini transannular patch. The VSD can be repaired either through a ventricular as a ventriculostomy or through a transatrial approach, accompanied with a mini transannular patch. If we are now going to discuss the transatrial approach, first of all, after incising the atrium, the first thing we usually is done is resection or thinning of the septoparietal trabeculations. After that, you have to note that the AV node is in close proximity to the VSD, so this area is important to avoid. Sutures are placed around the margins of the VSD, and then a patch is sewn into the VSD, closing the VSD effectively. After that, the mini transannular incision is made, and subpulmonary muscles are resected. This picture shows the technique for the shunt for the Blalock Helen-Tossing shunt. This is the subclavian artery, the right pulmonary artery. In this case, this is the right shunt, and this is the shunt itself. One area important is that in this operation you have to avoid injuring the recurrent laryngeal nerve, which can lie in close proximity to your incision. In patients who need a monocusp, usually patients who need a classical transatrial patch usually are treated with something called a monocusp. A ventriculostomy is made, and then the cusp is fashioned from a pericardial patch. It's sewn into the ventriculostomy, and the patch is sewn as a roof of this monocusp. Other approaches include intraoperative balloon dilation of the pulmonary valve or PDA stenting. Intraoperative balloon dilation can be done antegrade or retrograde. However, it has been found that people who underwent intraoperative balloon dilatation had similar outcomes with those who underwent transannular patches after 7 years follow-up. They had the same rate of pulmonary regurg. PDA stenting can be usually reserved for patients with severe pulmonary stenosis as an alternative to systemic pulmonary artery shunting. stenting of the RVOT in symptomatic neonates with tetralogy of Fallot with unfavorable anatomy, such as hypoplastic pulmonary arteries or significant comorbidities, has been shown to have some acceptable results. Post-operative complications, the most common are junctional ectopic tachycardia, non-sustained ventricular tachycardia, and heart block. Other complications include post-operative bleeding requiring reoperation, neurologic injury, renal failure requiring temporary dialysis, and residual VSD or even residual RVOT obstruction requiring the intervention. However, these are quite rare. Early reoperation rate has decreased from 3% to 1% in the current era, actually. We'll now talk about tetralogy of Fallot with pulmonary atresia, another subset of tetralogy of Fallot. So pulmonary atresia with ventricular septal defect and major aortopulmonary coronary collateral arteries, or otherwise known as MAPCAS. So tetralogy of Fallot with pulmonary atresia is defined as a congenital cardiovascular malformation that is a variant of tetralogy of Fallot, in which there is no direct communication between the right ventricle and the pulmonary arterial tree. It occurs in 10 per 100,000 births. 30% of patients have DiGeorge syndrome, and 3 to 4% of patients have Alagille syndrome. The embryology of this subset of tetralogy of Fallot is that in very early gestation, the human fetus has blood vessels that originate from the systemic origin, usually from the descending thoracic aorta, and supply blood flow to the lung. At about 20th day of gestation, the right and left branch pulmonary arteries fuse, and they are supposed to connect with the right ventricular outflow tract. When they connect, that should signal to these arteries that supply the lung to become involuted. However, if the connection is not made, these arteries, these MAPCAS, will persist to provide blood flow to the lung. Shown here in the picture, as you can see, this is the collateral arteries, and they originate from the descending aorta, as I said, and the diminutive pulmonary artery, as you can see, a diminutive pulmonary artery and the branches as well. Echocardiography is almost identical to that of tetralogy of Fallot. You have the right ventricle here at the VSD, and the aorta also straddles the VSD. This is a parasternal view of the pulmonary atresia of tetralogy of Fallot, also showing the VSD and the straddling of the aorta. This picture here shows the atretic pulmonary valve. So the majority of these MAPCAS originate from the anterior surface of the descending aorta. They may take an alternative course. Sometimes they traverse behind the esophagus. The MAPCAS can also originate from the subclavian artery, from the nominate artery, from the thyrocervical trunk, and rarely from the coronary arteries themselves. This picture shows patients with a retroesophageal course of the MAPCA. In this patient, this is a patient with right aortic arch with also a retroesophageal MAPCA. Around 27% of patients with MAPCAS have anomalous coronary artery pattern. The most common one is that the LAD originating from the RCA, same as in patients with tetralogy of Fallot. These are some of the coronary anomalies. As you can see, sometimes you have a single ostium, single coronary ostium. Sometimes you have the LAD arising from the RCA. So patients with the MAPCAS have a non-restrictive malalignment type VSD, same as with tetralogy of Fallot. By definition, this means that the right and left ventricles will function at identical systolic pressures, and that the two ventricles will have identical wall thickness. The presentation is similar to that of tetralogy of Fallot. Patients usually present as neonates with a combination of cyanosis and cardiac murmurs. This condition is diagnosed by echoangiography and CT angiography. Angiography plays an important role in this disease. As you can see here, this is the main pulmonary artery. This here is a MAPCA. This is a MAPCA originating from the subclavian artery. And this CT angiography shows a right aortic arch with a MAPCA originated from the descending thoracic aorta. Sometimes patients with sometimes it is important. Why it is important to send the patient for coronary angiography is because there are some lesions that, if identified, will change the course of treatment. The patients may have to undergo a different type of surgery. Sometimes a patient may have a ductus to the right, to the left, ductus to the lung, as in this case, this is a ductus to the left lung. Sometimes the patients may have a hemitruncus to the left lung. And thirdly, the patient may have dual MAPCAs, so that MAPCAs originating from both the right and left and supplying both lungs. And in this case, the patient may have to go on a different type of surgery. And patients with dual MAPCAs, usually will send the patient for something called as an aortopulmonary window, in which you anastomose the pulmonary artery to the aorta. And that will lead to development of the pulmonary arteries. They will grow because blood is flowing through them. And usually this is reserved if, as I said, that there is dual MAPCA and that there is arborization, meaning that the pulmonary arteries are in complete continuity with all 18 segments of the lung. If that is the case, then the aortopulmonary window is an excellent choice for these patients. If left untreated, the MAPCAs have quite a poor survival rate, with 10-year and 20-year survival estimated at around 50 and 20% respectively. So medical management is actually limited. However, in patients who present with congestive heart failure, you may usually are put on anticongestive measures, but there is limited role for medical management of this disease. Surgical management is the mainstay. About more than 75% of patients usually qualify for unifocalization strategy. It is usually performed between 3 to 6 months of age, because older neonates, older infants can tolerate the lengthy procedure. Apologies, this picture is not very clear, but basically, what happens during a unifocalization is that the MAPCAs are ligated and they are anastomosed to the pulmonary arteries, the branch pulmonary arteries. This is the final result of the operation, and they would put a homograft conduit from the RVOT to the pulmonary arteries, and they would put a homograft patch on the pulmonary arteries themselves. Another strategy that can be used is something called rehabilitation procedure, in which you sew a conduit from the pulmonary artery into the to the aorta, side-to-side anastomosis, or a conduit from the RVOT into the pulmonary artery. Other methods of treating MAPCAs are stenting, balloon stenting of the ductus. If the patient has a unilateral MAPCA, usually we will need to stent the ductus, and ballooning or balloon dilatation of stenosed pulmonary arteries can sometimes be used. This is my reference, and if you have any questions.
Assalamu alaikum.
Assalamu alaikum.
Do you mind if I add one extra information, basic information regarding the TOF?
Of course.
I read some times ago in a book called Park's Pediatric Cardiology regarding the TOF definition. I think you only mentioned the classic definition, which entails the 4 lesions.
Yes.
But there is the one I think that is more clinically important for the diagnosis, from what I understood, which they call the physiologic definition of TOF. So in case to diagnose a child with TOF, you only need RVOT obstruction, regardless of what is the lesion. and a VSD, but not any VSD. They said the VSD has to be large enough to equalize the pressure between the RV and the LV.
Yes.
And they mentioned also that the size of the VSD has to be around the size of the aortic annulus in order to reach this hemodynamic result of equalization between the RV and the LV. The overriding aorta sometimes is not there, and the RVH, it's just a result of the RVOT obstruction.
Exactly. Yes.
I think this is something I was also surprised that when I read, because every time I read about TOF, I have not seen such a definition. I hope it helps.
No, thank you very much. Thank you. Okay, since there are no questions, I think we can end the lecture. Thank you very much, and have a nice weekend.